Well, thank you for joining us today. I'm sorry Dr. Wakely couldn't be here. But why don't we start it off with really talking about lung cancer. Maybe start with Dr. Sung. Talk about lung cancer in Asians. You're a pulmonologist. You've spent a lot of long career working with the Asian community. Obviously, we got a little bit of a primer there from Dr. Wakely, but just if you could tell us, how lung cancer impacts Asians and what you've seen and how things may have changed over the years.
Yeah, definitely. Thank you for having me, first of all. I would say over the last decade or more, I've been practicing my field in lung, and particularly in lung cancer, about a little bit less than 20 years. Starting in Manhattan, I was in Manhattan, Chinatown. Then now I'm involved with Stanford last decade, also involved with some Chinatown population. I think that there is, within the Asians, I think when we talk Asians, there is such a broad term. There is the very educated Asians. I'm a first-generation immigrant. When you say that, you think about someone who came from somewhere, had a tough upbringing, and come to US and work hard. But no, that's not necessarily the case. I had a great education in Hong Kong, and I understood everything. I went to medical school. So when you talk about Asians, there is such a various aspect of it in terms of socioeconomics, education, understanding of what a lung nodule, a spot is. The effort as a doctor, it's very variable. I would say that we know that lung cancer is the #1 killer of any type of cancer, but we have one of the most fantastic screening tools. I tell patients who come to say, a CAT scan is almost the best tool because it's so sensitive. The good news is that it picks up everything. The bad news is that it picks up everything. But the fact is that it behooves you and your doctor to talk about what is the right thing to do. And I think that within the Asian community, if I were to talk to someone like you, it would be a very cohesive, cognitive, engineering type of conversation. Have all the Bayesian analysis, pre-test, post-test probability, and I can have a field day on it. But when I go to Chinatown, patients do not know why they come. They don't understand what a lung nodule is. They certainly don't understand what a pleural effusion is. My field, as Jeff would talk about, is that if you were to have lung cancer, you want to see Jeff because that's the cure. When we're the lung doctor, most of the time we face with that initial shock of delivering that potential bad news. And in that population who are the less proficient in English, they're the one that gets affected the most. They have more likely to be diagnosed as stage 4, but they tend not to, even if they get to the first CT scan, they don't follow up. So it takes a lot of effort in terms of engagement, and I think that that's where the effort is going to come to be. And now being in Chinatown, I think that the key for me is that as a physician, and I enjoy it, is that you got to be in their house. You cannot be the Stanford faculty and go, I go hit and I go run. You almost need to be within the community because in Chinatown, it's that word of mouth. You're part of that group, you're part of the community, you want to be involved, you build trust. And with trust, then they don't say, why are you talking about me talking about smoker, being a smoker? They get very defensive about it. But so I ramble a little bit, but my point being is that the key is to talk about the man who smoked and really talk about lung cancer screening because it saves lives. For the women, it's the non-smoking Asian women, which is a story, is to say, be vigilant about your symptoms and enroll in clinical trials like something Jeff is doing at UCSF. So I'll stop there. I ramble a little bit, but that's my Gestalt perspective, just for the first sentence.
Fantastic. Yeah. That's very helpful. And gives a lot of topics for continuing our conversation. Yeah. Before we continue on to that, I do want to, since we've got a interventional pulmonologist and a surgeon side by side, who gets, you get a CT scan and there's something of concern. Should that patient see an interventional pulmonologist or see the surgeon? And when should they see one or the other? What are your thoughts? And then we'll go to Dr. Philip.
Well, luckily, interventional pulmonologist, when I went into the field, it's not like now. When I went into the field, when I see a CT scan, it's usually stage 3 and above. That's when I can do a biopsy of the lymph node in the middle. I can drain the fluid when it's stage 4. So why that is, to me, that is both a blessing, definitely not a curse, because it builds the humanity of why I became a doctor, to handle how to deliver news. And that borrowed that experience to tell my mom that she had stage 4 cancer as well. But with that, I think that I think it holds true that we have great relationships with surgeons. And that to me was unique, and that's what made me thrive, because I want the patient that to be able to see Jeff, or Jeff has something that needs something for a lung doctor to do. But for me, I think that the responsibility for lung surgeon, for lung person, a doctor, is to try to remove the barriers. To remove the barriers of understanding the screening, the barriers of what a lung nodule is, to remove the barrier of what is the low-risk nature of a biopsy, and what is the curative nature of surgery. And the chemo, the biologics, the biomarkers. We should not be a barrier to make sure this informed decision to get a CT scan. It should be your underground, your nurses, your MAs, because that's no longer valid. So Jeff, what do you think?
Yeah, absolutely. Exactly what Arthur had said too. Thank you for having me, by the way, as well. That it's really, I mean, I know this is going to be a cliche word for everybody, but it's going to be that multidisciplinary approach, right? So it really should be both of us. And that's how it really is now. It really is now, whether now you have like lung nodule teams, lung cancer screening teams, but like in my practice, and then I'm sure over at Stanford too, it's a combination approach where pulmonology, radiology, and us as thoracic surgeons will be looking at this to decide, what's the next step? Does it need Arthur to do a biopsy, to do mediastinal staging? Does it need to be drained? Can Arthur do the biopsy? Does IR need to do the biopsy? Or do they go straight to surgery? Right? And so I think that it's both of us. So I do think it's a collaborative effort, and I think that's the ideal situation. I think old school would have been, I think what Arthur was kind of getting at, it was like, you just see the pulmonologist for something, or you just see straight to the oncologist, or you just see the surgeon. And I think nowadays we're trying to really say that it should be collaborative, because, and you're going to hear difference of opinion. The way Arthur may explain something, it might be slightly different than the way I may say something, the way a medical oncologist may say something. So I think it's good for you as the patient to kind of get that collaborative feel. So I should say, like, I mean, maybe this probably doesn't happen at Stanford or Kaiser or wherever, but I will say in the community, you often don't get opinions from other doctors. It might just be your primary care doctor, which is okay, but Dr. Lin may not be a specialist in what this lung nodule is, right? And so it's up to you all to be a little bit proactive about your health. And I think Arthur was getting that too in the community, and that's what we're trying to go to the community. But how often can we get out there, right? We're busy, you're busy, and you're limited, but you need to say, hey, what about this? What about this? Should I see this person? You're not being annoying. Right, you're not being annoying. You're not being, you may not understand it as well as with English proficiency and all that stuff. So the other thing I say, and I don't know if this is not maybe a popular topic, but I say get your kids involved. Okay, and if you don't have kids, that's not the end of the world, right? But your kids can really help. I often do a lot of the talking because I'm Japanese and I don't speak Mandarin or Cantonese. I don't even speak Japanese, right? But I can rely on the kids in the other, or the family members. Bring somebody else to help you in doing that, because they'll understand, or they'll ask the question of like, should I see Dr. Sung? Should I see, me? Should I see Dr. Wakely? Things like that. So that's kind of my take on that.
Before we move on to Dr. Trivedi, I wanted you to share, you were very kind and came to speak to our class in the fall and talked about epidemiology, and Kaiser's got a huge set of data to look at. So from the Kaiser data perspective, can you give us an update about what you're seeing with lung cancer, both in smokers and non-smokers? And you don't have a slide deck, sorry, so you gotta.
I'm ready.
You're ready.
For it. Yeah, no. I mean, Arthur and I were just talking about this. He was like, "Your database is so great."
Yeah.
Yes, there's good things, and there's pros and cons to everything. But yes, our database is great. And so, to elaborate on what Dr. Lin's talking about in his class this last fall, what we really looked at, right? And not everybody has to be Kaiser patients, but it was all looking at Northern California, which is if in Northern California, there's about 4.5 to 5 million of us all that happen to be Kaiser members, right? Whether you're Asian, Black, white, whatever. And so when we looked at that, we could actually tell you based on, not smoking history is not always accurate, but pretty accurate enough in our system because we ask you, we harass you enough at our, at our place or whatever, right? Or that we can have a denominator. So what that means for everybody is that we can tell you incidence. And it's the only study that we know of, at least in the United States, a real world population of all of us, of what's happening with lung cancer in men, in women, and then break it down by race, ethnicity, smoking status, right? And so part of this invisible disease, I think, Dr. Wakely, I'm going to take that with me. I know about the invisible disease, but not like, oh, the air is invisible, and then the stigma is invisible, but anyways, so to tell you about truly invisible is that lung cancer, all of the lung cancer in men, women, smoking, non-smoking, race, ethnicity, everything lung cancer incidence is decreasing as we speak. So the misnomer is that there is no lung cancer going on, right? Or lung cancer is the Marlboro Man, and that's old. And we don't see that anymore. And that's true. We don't see that anymore, which is what Dr. Wakely is seeing. However, the one group we do see an increase, and it's increasing 2% per year now, like even now, and could even be higher because this study came out 2023 in CHEST. Asian American non-smoke, all Asian Americans, all of us here, like we couldn't break it down by each, Chinese versus Japanese, things like that. But either way, Asians as a group, non-smoking, men and women, we see it more in women, but this is why I really focus on Bryant's class because we see it in men too, non-smoker men. That is increasing 2% per year. That is where the lung cancer is increasing. That is where we should be focusing a lot of our efforts in. And that is where I think we need to do a better job. Second plug for Arthur was talking about it a little bit too. Guess who is diagnosed more at stage 4? It's our Asian non-smokers because Arthur made a good point. Screening is everything to catch it early. There's no screening exam for Dr. Lin. There's no screening exam for many of you out there that don't have a smoking history of 20-pack years or a current smoking history. So we also looked at our data and we looked, the majority of our lung cancer that we saw in non-smokers and Asian, they were women, but more, like Dr. Wakely said, more of them were diagnosed at around 50 or less than 50. The normal average age of lung cancer is about 72. In Asians, it's 50. And then the real thing is that the majority of them have EGFR. 63% will have EGFR mutations, whether you're a man or a woman. So that's good in a way to have that targetable mutation. But the sad part, and this is what we really need to work on, whether we're not Taiwan where we have these CT scans for all Asian non-smokers, which I wish we would have that here, but it's another issue. But the majority are diagnosed stage 4, or they're diagnosed stage 1 because you got in a car accident and you got a CT scan, you got lucky. So incidentally, right? Stage 1 or stage 4, the majority are stage 4, and that's what we need to change. We need to change that to earlier by. Right now, before we can do these screening CT scans, we just have to be more awareness. So if you have a cough or something and you are Asian and you don't smoke, don't think, oh, it's nothing. You got to get that followed up. So that's kind of what we found, and so I'm hoping that you all take that with you too when you're talking to family members. So
can we, after the class, we had a brief discussion. It was like, who would you recommend screening for? You'd have to pay out of pocket. I talked to Dr. Natalie Louie.
Yeah.
She gave me her recommendation. Actually, I worked with CARE, and because we don't have any guidelines, I put my name on a sheet. Like Dr. Lin recommends, blah, blah, blah. What do you recommend?
So yes, everybody has their differences. Right now, the screening study and Dr. Louie's got her screening study started. So it's good. We're at least getting that out there. We need to get more out there where there's funding not. But the highest, and this is based off of the talent study a little bit.
So the Taiwanese study. Yep.
The Taiwanese
Big Taiwanese, 12,000 people.
12,000 people, but that show that they did pick up more early stage lung cancers and that they picked up 2.6% of, so double the amount of what we found for lung cancers in smoking individuals from the NLST trial. So we found double that. Again, so they're doing that routinely in Taiwan. But the highest risk that I recommend is, and this is for whatever it's worth, it's not 20, 30, 40. Yes, we will see that in 20, 30, 40 years every once in a while. It's 50 and above, okay? 50 and above, and if you're Asian, non-smoker, right? In this population we're talking about, right? We're not talking about the regular screen population, but a family history. Family history is the strongest part, and that is the strongest factor. And in fact, in the talent study in Taiwan, that's what they found. In fact, your risk goes up triple every amount of family member that you do have that has lung cancer, and it goes up even more if it's on your maternal side, if it's mom's side. Okay, and so right now, my recommendation for what the screen said that we're going to open up soon, 200 patients, is if you're greater than 50 and you have a non-smoker, Asian, whatever, doesn't matter what Asian, any Asian, and if you have a family history, and the more family members you have, the more you should get in to be seen. So that's my quote unquote recommendation for that group.
Fantastic. Yeah, I think Dr. Louie kind of splits the difference. For women, 45, men 50. I went the other way, just with an N equals 1.
Yeah.
Right? I was diagnosed at 49. So what I wrote on the paper was do it at 45. And if you're, again, family history, you see, I think there seems to be a consensus, at least among the three of us, family history, East Asian descent, not covered by insurance.
Correct.
No guidelines.
Yes. You'd pay out of pocket right now if you did that.
Yeah. I think at Stanford, it's 500 something. Silicon Valley Diagnostic Imaging is about $150. So not bad.
There are some clinics in the South Bay side that will offer scan and or MRI is not as good, but MRI will show something, and they call it like a chest CT scan for about 500. So there are some local Asian clinics that are aware of this, because that's what they do in China. In China and or Taiwan and Hong Kong, you could go and get your CT scan there. You could go back. We get a lot of patients that go back, get their scan, and they find something. And it's not that they get, China's got a lot of great surgeons and or doctors, but China's so big, there's a lot of rural areas too where they don't have that. So they'll come back because they have family members here, and they'll show us their scan, and then we'll go, okay, now we have to get something because you have a documented nodule that we found. We don't know if it's cancerous or not, but once we find that, then we get our scan, then you're back in our system. And I've treated many individuals like that, that are early lung cancer. That's fine. You chop it out and you'll be fine. Yeah.
Thank you. And Dr. Trivedi, so many things that Dr. Song and Dr. Volota have talked about that relate to caregiving, family members, not speaking English or having limited English proficiency, different cultural issues, different access. So patient, abnormal CT at this point, got a CT somehow, maybe was in a car accident. What's the approach in terms of the caregivers? What should they do?
Thank you for the question. It was really fascinating to hear both of you, and thank you for having me. I will give the ideal, because what we do right now is basically not a whole lot to engage family caregivers explicitly in our healthcare system the way it is. I think ideally, and I think your documentary kind of documented Christine sort of being by your side in these visits throughout. Ideally, at that point, there should be an approach to individually talk with the family caregiver to see what they are taking away from this information. I love what you said about bringing the kids, because especially when there's language barriers or health literacy barriers, kids who are raised here or other relatives, they do become the de facto interpreters, and they understand the system better. Checking in with a caregiver, and they may not be caregiver yet, they might just be the wife or the child or the sister or brother, to see how are they making sense of it and what is expected of them. As it progresses to a diagnosis and then treatment, the caregivers do start getting more and more involved, and there's more and more that is expected of them. And what would be ideal is we as a healthcare system, and we as healthcare providers, know that they're being asked to do a lot. I was really struck by the image of the nurse running past Christine, and Christine just saying, "What's going on? I need to check up on this, and she was just reading her book. And I think those moments where the in this case, wife, the family caregiver is going, wait, were you going to tell me what's going on? I think that becomes really important. I think the bigger picture is that at each stage that when you all are treating, we also need to screen caregivers, screen how they're doing, because we know that as people become family caregivers, they're more likely to screen positive for depressive symptoms, for stress. They start experiencing what's called caregiver burden, which is stress as a direct result of caregiving. But again, with a lot of this research, a lot of it does not focus on Asians. And actually among Asians and other minority groups, it seems that there's actually a lot more joy as well. The social networks are wider. There's a lot more help that steps in to, so your sister was there. So I think we need to understand that better, how we, in the Asian world, how we approach this caregiving. We do know from national data here in the US is that Asian Americans and Asian American, Native Hawaiian, Pacific Islander all grouped together, as we know that happens.
And this is our month.
Yeah, and this is our month. And is there actually of all the minority groups, racial ethnic minority groups, they're the most likely to say that they don't feel like they have a choice in becoming a caregiver. It is just what is expected as a son, a daughter-in-law, a son-in-law, whatever the relationship might be. So for this particular gathering, I think that becomes also an important piece, because if you don't have a choice, then you're going to feel more stressed out about it.
In a related topic, and I think all three of you have sort of touched on this, because it relates to caregiving and language and culture, and Dr. Sung, you directly touched on it. Let's talk about healthcare access, and I see we have Dr. Segal here. He's our chief medical officer of the hospital, the adult hospital, and he's kind enough to give the talk in our class, lung cancer class, about healthcare access. But would love your perspective as a pulmonologist who's worked in different Chinatowns and with the Asian community about healthcare access, and what can we improve?
Well, number one, I want to align with all our speakers. What I see is that Asian families tend to be more multi-generational. In the family, in the close unit. So to have them be part of the decision making, to educate both the patient and the sons or daughter, I think it's very important, because a lot of the times I find myself leaning towards a little bit more towards the family who's there with them, because the older, I'm talking about the older ones, they tend to defer. Now, have I gone into a situation where the coaches told me, the son and daughter say, don't even tell my father that he has cancer? That is an ethical issue, but I tend to always say that, no, they're the patient, they have the right to know, but I certainly want you to talk to them first before we approach this topic again, and not to just jump right out and say, this is what you have. Because we have to respect culture. Cultural sensitivity is important. I kind of rehash my point, and I'm very blessed that Stanford has enabled me to exercise that freedom to again be the community. We are grooming the next generation of faculty now that provide direct care, that we are not dependent, which is great. We want to be teachers, but residents and fellows, they are the next generation, they are our future. But someone who's been our early to mid-career to be in academic medicine, but to reintegrate in the community, I think that part of it needs to be groomed in faculty. Because at UC or Kaiser, even at Kaiser, a lot of residents, you tend to just depend on them. But, and at the same time, the dichotomy also is that community physician, they do have a little bit of knowledge gap in terms of what is screening. There's studies by Sutter Health that actually look at, a community family practice versus academic family practice. the understanding of screening, it is improved with the academic side because there's that connectivity. So I think that to have that partnership, not to be one or the other, to have that quote unquote level of integration in the community, to groom that generation of faculty with the academic connectivity to a big center like Stanford, I think that's the way to do it. To go to outreach, to go to the Chinese New Year booth and talk about lung cancer without talking about, without them thinking that cigarette smoking was a sin, because everybody smoked in the 70s. So you have to take that guilt away. Take away that defensiveness to make sure that, it's important to be screened. So anyways.
And Jeff, you're at Kaiser, big integrated system. How does Kaiser or you deal with this community approach? People view Kaiser as kind of this big monolith, and it's sort of like you go to any Kaiser, you're gonna get the same thing.
Yeah.
How do you? But
it's like a big black box.
Yeah.
Right? Yeah.
But Arthur brings up a good point. Those relationships with the community are important.
Yeah, absolutely. So that's I think what he's getting at too. What Arthur's getting at too is that we should be doing that. We should be on the community, but it's more on the rare side. I think we got to teach that, and we have to be out doing that. And even for big organizations like Kaiser, it's very limited in what they could do. Like they'll be at Thrive City, and at whatever the Warriors and big things like that, and but specifically with the Asian community, I think it's different. It's different, and that Kaiser, Sutter, UCSF, Stanford. I mean, Stanford luckily has CARE, the Center for Asian American Research, Health, Education, but the rest of us don't have this, right? The rest of us don't. And so, you have people that need to worry about their own kind of communities of, if you want to call it color, right? You have people that want to get to the Latin population, and people that want to go to the Black population, want people to go to the women population, all different things, right? And so I think if we're going to talk here, let's be honest, right? We're talking, this is the Asian American population. That is an underserved disparity. I think, I don't know, you guys have probably heard me talk about this. Our problems never make the headlines, right? We don't speak up, we don't say this. So I think for Asian stuff, it's harder to get that done. So when I go out here, right, when I do this, and when I go out to the Chinatowns, I agree, like with Arthur, I'm not getting, it's not like, Kaiser, UCSF are saying, yes, here, go do it and do it. Look, this is all on your own, and that's what we have to teach the other physicians. So it's up to us, because we can't expect the big organizations to be like, oh yeah, we're going to support Asian Month, right? I would love for them to have a different thing for AAPI, but then they also have, it's also Women's Health Month in May. It's also all these other things that they have to do, and then you get into these racial things where, wait, what about this group, or what about that group? That these big monstrosity groups have to understand. So I'm not saying being a Debbie Downer. What I'm saying is you have to go out and do it on your own, and you need to rally people around you to do that. So whether it's Arthur, whether you have to continue to go out in the community, and then hopefully that people will pick up. I think the wrong mistake is you can't wait for the big organizations for them to say, we're going to have an Asian Day about lung cancer screening. We have never had that once in the 10 years that I've been here, right? It's never going to happen. But I'll continue to go out and do that until we can get that. And then maybe we can make waves by doing things like this, little things like this. And so I think that, that'll help. I hope that answers your question a little bit.
Absolutely. No, that's, definitely a call to action for our community to come together. Dr. Trivedi-Ronak, how should our community support caregiving and caregivers?
Within the community, within the healthcare system?
Both,
right?
Yeah.
So I think in the community, I think that term just generally, people don't realize that we're talking about us, right? Fundamentally, that term is actually, if you think about it, it means from the healthcare system's perspective, from the medical system perspective, you are the person who is caring for the patient who actually is my patient, right? So, but these people, everybody has multiple other identities. Their wives, their daughters, their students, their professionals, whatever they might be. So I think the first thing is to realize that if you are somebody who is caring for somebody who has lung cancer or any medical condition, then recognizing that is what is meant when people say caregiver. So fundamentally, an awareness of what that term even means is just lost. And the reason why that's important is because there's a lot of resources out there through state and counties and things, they'll say for caregivers, but people don't realize that means them, right? So there is that challenge. I think the healthcare access is an important question because we know that family caregivers, the term family caregiver is the current term du jour. It keeps shifting but there could be friends, it could be other connections as well. We know that when family caregivers are involved, their own health suffers. So having situations where if you are somebody who shows up to a chemotherapy appointment and you're waiting, that's maybe a great opportunity to ask them how they're doing and are they taking care of their preventive health? Are they taking care, have they gotten their whatever annual exam? Have they been following up for any health conditions they might have? Because we know that falls by the wayside. Literally you could have flu clinics and see people that need flu shots at the time because we know that that's where the focus goes. I think that's a great way to kind of cross that chasm. And we actually did a pilot study looking at screening of depression and anxiety and caregiver burden for family caregivers as they were just showing up for head and neck cancer appointments. And it was really striking to see how many people screen positive in just this random, like we're just hanging out in the clinics. So I think the communities, we should be aware that that's who we are. There's resources for that. And then from the healthcare system to recognize that when people show up as a group with multi-generational families, then those folks may have needs as well, and maybe carving out some time to approach them. And actually there's new CPT codes now that you can bill for seeing caregivers, which I think is something that hasn't quite gotten into the healthcare system where people know that they can actually bill for that, and that becomes obviously a very important way that we can engage family caregivers in a way that without kind of suffering the bottom line, which is often a concern.
Fantastic. Before I open it up to questions from the audience, I'm going to ask you all the same two questions. Ronak, you're a great researcher. You were awarded 2 NIH grants this year, or one NIH and another one. One NIH grant, another grant. So lung cancer is the most underfunded out of all kind of major cancers, especially considering it's the #1 cause of cancer death. Asian health research is really minuscule. One study showed 0.17% of NIH grants are awarded for Asian health. Senator Bernie Sanders' office on Tuesday came out with a report that said there was a 30% reduction in NIH funding for cancer alone since this administration took over. So first question, and I hate to ask this because it seems self-evident, but why is research important for Asian health? And second question, what do we do about this funding crisis? So we'll start with Ronak.
I'm also a VA employee, so I'm really glad that I'm not on VA time. So I get right now. So I get to
you won't get in trouble.
So I get to I can be a little bit more candid. I think why is Asian research more important? Well, 60% of people on the globe are Asian, so this is not a rare thing. I think it's just the way the funding has been dispersed. So I think the experiences of Asians there's the sort of physiological pieces that my colleagues and you all can speak to in a way that I cannot, that seem to be unique in terms of risk factors. I come from a social and behavioral perspective as a clinical health psychologist, and there's so many cultural aspects to lung cancer or any cancer that just has not been studied, actually, frankly. We recognize anecdotally, and there's pieces that will say, well, we know there's stigma, that we know there's taboo, we can look around, we know this. The disclosure piece that you sort of mentioned, the secrecy and disclosures, those are all prevalent in the Asian cultures. And but we haven't applied the research rigor to those questions to elevate those issues. So when we research a question and we build a body of literature, we have an opportunity to make a point to say, this is something that is a problem. And so this is a gap there's a gap in research, but now we filled that gap in research. Now we have another gap, which is what are we going to do about it? Because at heart, I'm a clinician. Like, I want to solve the problem. I don't just want to describe the problem. So I think that the Asian health, just from a global perspective, is a really important. It's a global issue. The diaspora, both in the native countries and the diaspora, there's Asians everywhere. And I think that we here have a far more prevalence of, there's a lot more concentration in the California and the Northern California areas, even compared to other parts of the country. What are we going to do with the research crisis? Advocacy is super important. I really love what you said about, like, we can't wait for our organizations to always take the lead. We have to personally, raise the voice and kind of make the issues, make people aware of what matters to us. And whether that means calling our representatives or partnering with other advocacy organizations and kind of doing those pieces, all within whatever people's bandwidths are, recognizing that we all have other lives that we're really just juggling, especially if you're dealing with a health condition. I'm hopeful. So I will say this, I am hopeful. I think, there's been a lot that has happened, and I think the tide is starting to turn. There's a lot of harm that's already happened, will happen as the tide turns, but I feel like there's a little bit, the levees are holding a little bit right now. So I will leave with that message of hope.
A little optimistic
with a
note.
little optimism. I'll channel the Bryant optimism.
Arthur, do you comments?
Well, number one, Asians are the fastest growing population
In the U.S.
in the
yes.
U.S. And we are very much in the labor market. And there's so much research question that it's not just lung cancer, but I think that, to me, to be able to address a lot of population-based research is so important. Yes, screening is a population-based research, but Asians itself has very unique metabolism. There's a whole field of metabolomics now. For me, I got a BMI right around 20, which is actually not, for a non-Asian, that's like skinny. But for an Asian, 1 in 2, based on my BMI, is pre-diabetic. So, and we have also been finding that people with pre-diabetes, the progression of cancer does not favor as good, those does not. So there's so many in cultural research and in terms of busting myths, there's so many myths involved with cancer and cigarette smoking, and when you do a biopsy, does it spread cancer? So there's so much of that that's also in play that I think the research is rich with, I do think that big institutions such as Kaiser, UC, Stanford really need to coalesce our efforts together to answer all those questions, because it's not just answering the questions for Asians, but by doing so, you're addressing that for the whole humanity. So that's my take.
None of us work for free.
Correct.
How do we get the funding for this?
I
work for free, but not for this.
I do think working for free is volunteerism.
Yeah.
Yes.
Right?
But
I
not
think
sustainable to
it's
create
not
a big thing.
sustainable.
Yeah,
I think that there's so much non-clinical work that clinician can be involved with. Be part of the lobbying process. Be part of focal voice that says that where's that awareness of Asian lung cancer or non-smoking cancer that directly relates to Asian. It is a population that's growing. There is that sub-cohort that's favoring to be worse off because of the non-smoking status. I think that raising the awareness doesn't cost money. You just have to voice. And I think that collective efforts can help. A little bit helps. And hopefully with time, with the next administration, maybe that tide will change too.
we may have to.
I shouldn't have said I'm first generation immigrant because ICE has got knocked at my door.
ICE comes in.
So.
Okay, Jeff, the question goes to you.
All right. Well, my panelists had some great stats, so I got to pull one out too to make it relevant for Asians, right? So, Asia right now in the Bay Area, if you look at the whole Greater Bay Area, Asians actually make up the highest population. 33.1% of all of our population in the Greater Bay Area are Asian. Non-Hispanic white, 32.5 or something like that. And then the rest, Latin, Black, but it's Asians, right? So that really matters here, I would say, more than a lot of places. Southern California is something similar, but maybe not. So you can't necessarily expect even New York, Texas, Florida, I don't know, bigger cities, right? Bigger states. You can't necessarily expect them to be pro-Asian, right? Because the Asians are all here. Hawaii, yeah, maybe, but there's only 1 million people in Hawaii, right? Most of them are Asian, but Hawaii is its own little, I love Hawaii, but it's its own unique thing. So we have to do that here. And so to talk about why we have to study Asians, so Dr. Lin had a great stat about 0.17% of funding, but I will tell you the clinical trial participants in everything, not just cancer, but everything, is less than 2% are Asian. So we're studying all these drugs, we're studying everything, except the osimertinib, that's different, that was done a lot in Asia, but everything else is not done in Asians. So how do we know what's gonna be right for us, right? If it's not studied in Asians, right? And we gotta do that in California. And I'll give you just 2 more facts these are actually facts that we looked at, because this is something that I'm interested in, because I tend to see a lot of Asians, not just because, but because we're in this area, right? But also Asians tend to come to me too. For example, Asians in lung cancer, and this is hopefully going to make Dr. Lin feel better. If you adjust for everything, for socioeconomic status, comorbidities, age, smoking status, Asians actually have the best survival for lung cancer, regardless of stage. So there's clearly, like Dr. Sung's saying, there's clearly something different going on in our Asian population versus white, Black. And then if you disaggregate it, we even disaggregated the data. Yes, most of the Asian subgroups all do better. Chinese, Vietnamese, Filipino, all do better in lung cancer. Yes, they get diagnosed with more of stage 4, and yes, many of them don't smoke, but they're doing better regardless of that. So we need to continue that effort. That one, we want to get them, prevent the stage 4, but even if you do get stage 4, they're going to live longer. So it's not a death sentence anymore. You can live normal lives. I mean, the EGFR could last for 10 to 20 years, right? I know we're talking about morbidity, but morbid stuff, but there's good factors for us. So we need to study that more. This is really going to be one of the first studies that's going to show that. And it's been hard to publish because it's like, well, race is kind of funny. It's weird, all this stuff, but it's true. We see that clinically. And so that's why it has to be done in you all and doing that. And so I think that's kind of there's differences. And then the last thing is, what about pain meds, right? How many of you had surgery? Not just lung surgery. I did it for lung surgery, but any surgery. Asian men and women, especially Asian women, you can't tolerate pain meds. You get super loopy and you vomit, right? There's actually physiologic things related to Asians, regardless if you're big, fat, small, skinny, whatever, it doesn't matter. It's not weight-based. That's how we go by oxycodone and all that stuff. It's Asian. We saw it when we took away the weight-based, all the comorbidities, are Asian people versus white and Black and Latin can't tolerate pain medication. And so people were forcing down oxycodone on you, but I no longer do that because you can't tolerate it. So we have to give you something else. So little things like that. I know it's small, but it's true and it's there. And so I think we need to further that effort. And then lastly, for funding, I don't know if this is a popular thing. This is what I've done. I'm lucky I'm not as strong of a researcher to get NIH funding in the first place. So I've never had NIH funding, right? Because for me, you don't want to come to me for research. You want to come to me for like, if I'm going to cut your cancer out. But so I'm lucky. So,
or if you want a lot of data from Kaiser.
Right. It's industry funding. Utilize industry. Guess who makes all the money with all this cancer stuff and all this stage 4 stuff? It's all big pharma, right? It's the surgery companies, like, right? Did your surgery happen on a robot? Do you know how much Intuitive? If I own stock in Intuitive right now, I'd be, set, right? These are monster markets that have all the money, and believe it or not, they do want to help. They want to offset their taxes too, and so they will give money for industry funding. I have a ton of industry funding. All this database stuff that I've done, that you heard about, all the Asian studies, this is utilize them. They're going to utilize me. I'm going to utilize them to get the money. I can't just spend money on my analysts and my researchers and all this. All this money was funded off of industry funding. So that's where you have to go. You have to be unique about it. You could say people always worry about conflict of interest. You could put down research funding going to the Kaiser nonprofit, research funding Stanford going to wherever, VA going to the VA. They could fund that. That's how we have to get. We have to get out of our snooty, like, I need to get NIH funded or whatever. Good luck on that now, first of all. And then, so to get industry funding, and that's how you get stuff done. And if you get past the snootiness of like this old school way, that's the way you get it done. They'll give you 200, 300 grand for really good grants. It goes to your nonprofit organization. Stanford's got its nonprofit thing or whatever. It doesn't go to me, right? It goes to fund the analysts and stuff. And I think that's how we push it forward. And I think industry knows that too. And they want to catch this early. They want to catch things early too. So that's my big plug from a research standpoint.
Can I also make one plug? I love the point and that you made. I also just want to put a plug since we're plugging things now. We're the plugging part of the panel, the plugging panel. If you haven't heard, the UCSF, Van Park and her group are maintaining have created and maintaining a registry that is specifically funded for Asians for future research. So it's anybody, you just sign up and you put in whatever your particular characteristics are. I see a lot of nods, so that makes me very happy. I'm on the advisory board. And so encourage that. So I think there's two sides to it, right? We need to, as researchers, clinicians, as people who can drive the program, we need to focus on this more. And with the communities where they can help us sign up for this registry so that you can always say no if somebody reaches out to say, do you want to do this study? You can always say no. It's just a place so that if people are looking for doing research with just for Asians or with a subgroup of Asians, whatever, then we have a cohort of people that we can all draw from. So that's my plug. Great. What's your plug, Dr. Song?
I agree with Jeff. I'm at Stanford. My senior associate dean is here, but I hope he doesn't fire me. But I think industry money is important. We just have to use it responsibly and ethically.
Right.
I mean, I go back to example, like 15 years ago, Claudia Henschke, who is one of the premier screening person, she published money from Philip Morris. She was grilled to town, but her data was important to spearhead a lot of the data that came out with NLST, Nelson. So I think she's still at Mount Sinai. It was like a prestigious professor.
Yeah.
I think that we just need to be able to segregate what is used ethically, responsibly. Pharmaceutical companies, they're the one who makes the next generation and next generation. When Tony Mock, the study from Hong Kong U, with Alana, that was the initial one that just raised everything, right? Now we have Tigrisso, we have the next generation. It's a pharmaceutical company. They have grant in A section, educational grant section, that can segregate that aspect of it. So I think that there is that avenue that we can harness that partnership and not be necessarily be viewed as a traitor. So that's all. That's my plug. Is that okay? Can I still say it?
Too late now.
Oh, darn.
Fantastic. Great responses.
Is it their ice or Segel for you today?
Huh?
Is it their ice or Segel for you today?
Oh, that's right.
I forgot to coach you on the answer because I have the answer.
Oh, okay. What is
So the answer is you need to donate to CARE. And all joking aside, Nina has a QR code. So I'm going to open it up to questions from the audience, please. Yes.
What percentage of the Asian lung cancer patient that is responsible for the EGFR medicine, oral medicine? And is there any like a gene marker that you can sequence and then detect that you're vulnerable to certain lung cancer?
I don't actually know what percent of Asians who have lung cancer have EGFR.
No, yeah, we do. So we do know that. About 67%.
Okay.
Will have EGFR. And then to answer your question, and I think Dr. Wakely did a good job of trying to explain basically a somatic versus a germline mutation. So what that means is the majority, unfortunately, of the EGFR mutations that we see in Asians, yes, it's good that you have an EGFR mutation. We have good targets, and we think that's good biology, and it can respond well. But the majority are not passed down from family to family. So even if you have a family member, say mom has it, and you get it, that isn't necessary. You can be tested for that. So there is a special germline mutation test that you can test that is EGFR can run in families, but that's actually about 1%. So the majority of the EGFR mutations that are in Asians, unfortunately, are not family history. Maybe, or fortunately, however you want to look at it. So it's usually not germline where all these family members are going to get it. It's very rare. You may have one or two that have it, but the rest don't. So in a way, it's good. But in a way, also, it's unfortunate because it's not like what we have for breast, for BRCA, BRCA, what we know about that. For EGFR family history, EGFR germline mutations, it's a lot less rare. However, with that being said, if you have multiple family members with it, like mom, grandma, sister, I have a med student like this that her dad, it's like, anyway, I won't get into it, but there's multiple people. That is a test where, again, you can get tested for germline mutations for everything if in that certain situation. So certain hospitals are instituting their own policies. For example, Kaiser does institute, if you're less than 50, you have lung cancer, and then you have a family member that was diagnosed, like a first degree relative that was less than 50, that was lung cancer as well, EGFR, you can now get covered for genetic testing counseling. Before, right, it was like, or a majority of times, like you come and then we tell you, no, you don't qualify or whatever. But now people are taking that into account. So hopefully that answers your question.
I just want to clarify, but like you said earlier, and Dr. Wakely said, family history is a huge risk factor.
Yeah.
We just don't know why. We don't know the genes or combination of genes that increases your risk. So therefore we can't test.
Right.
Because we don't know that.
Right.
And that's why we need research, and that's why we need funding.
Right. We don't know the why. But if you do have, in some cases, we do know of family members that all have had EGFR.
Right.
And so, but that's very rare.
That's
like
rare,
we said, like the 1%. So like Dr. Lin said, we need to figure out the why. Yeah. Absolutely.
So 3 hours ago, I was across the street getting a CT scan that will determine whether I have cancer. So I have 3 questions for you. One is, when you're in that waiting stage, how did you manage your mindset? Question 2 is, how do you advise patients who are in that situation? And then question 3 is, how long do I have to keep this going?
You can take it off now, yeah. It's usually 20, 30 minutes for like IVs and phlebotomy at most, as long as they wrapped it tight. The biggest thing is they don't wrap it tight and you get a bruise afterwards. This should be really tight, yeah. So to answer your other questions, I think I was, again, privileged because, I'm part of the healthcare system. So, and I know what's going on, so that waiting period was more of an evolution than a absolute, like, I know nothing and then I know something. And again, I was diagnosed from x-ray to pathology in 6 days. And great thanks to my colleagues and Dr. Sung as well, who got me in for bronchoscopy very quickly. So thank you. And so yeah, but that to me that should be the rule and not the exception, right? That should be the standard. Everybody should get diagnosed that quickly. The question is how do we get that done? I think the mindset is, it's tough because you don't. It's the unknown, right? That's why fear is frequently because of the unknown, right? And I think having that family support, honestly, doing what you enjoy doing, getting distracted, and but not. I wouldn't. To me personally, everybody's different. Not focusing so much on the unknown because you don't know it yet, right? So why have your mind go there? And sorry, what was the second part of the question?
How do you advise your patients?
Yeah, so that's how I advise my patients. And what I do practically is I try to do my best to accelerate things, right? Just like with any diagnosis, right? So you call up, radiology, and you're like, hey, this report's not back yet, right? You call up pathology, hey, the report's not back yet, right? You do all those little things to try to speed things up, and you try not to, because you try not to have that result sit there and until you got to remember, well, I got to check, this is an important timely result, I got to check that. I had a patient today, it wasn't cancer but something else, so I remembered I checked the result right after it came out, so I could go and call that patient and give them their results and act upon it. So, but it's a great question, difficult, yeah.
I just want to point a very important point that you raised, that CT scans, financial aside, it's a very low price to pay. Number one, it actually is non-contrast. The radiation dose,
low-dose CT.
Low-dose CT, that's lung cancer screening. It's now to the effect of photon-emitting CT scan is pretty much less than what we call 1 millisievert. I think just living in California is what, 3, 4?
3, yeah.
3. So So we used to get worried about the con, right? The shared decision making. We worry about overdiagnosis, right? That you are now having like the prostate cancer situation, where you have a PSA a little higher, you actually have prostate cancer, it just never does anything to you. But I think that also you need to know that for smokers who get a low dose CT scan, pretty much 1 in 3 will have a spot. But even in smokers, most of the majority, those spots will turn out to be benign. Just to empower yourself with the knowledge, then to have a discussion with it. So that's where the shared decision making is from, to go to a CT scan. It doesn't have to be a doctor, but once you do, you have that mindset, be prepared that, yeah, I could have a spot. That's the whole reason why I'm doing it. But that's what you want to get at, is that if I have one, I stay shifted to a stage to go to this guy, and to understand that is something that is continual basis. That's important. So I just want to raise that point.
Fantastic. More questions?
I know today's talk is more about the care of it once you get the cancer, but I was wondering, like, is there any research done about what triggers the gene to cause cancer? Like, is there anything preventative regular people can do? Like, is it like pollution or what we eat, something,
So that's what, and Dr. Wakely's on that. I'm also a co-PI on that. It's based out of UCSF, but it's a collaboration with Kaiser, UC Davis, Stanford. Who am I forgetting? I got everybody. Stanford, UC Davis, UCSF. They're the one. Scarlett and Gomez. Sorry. So it's called the Female Asian Never Smoker Study, and the idea is to study all those things. So we're looking at women, Asian women, non-smokers that have lung cancer, and 600 that don't. And we're comparing that. We're closing that study in July, and the idea is we're asking all those questions: pollution, where did you live? Did you live in China? Were you born here? What was your secondhand smoke? Did your husband smoke? Like literally, and some of you may have already filled this survey out or went as a control or not, but that's the idea. This would be the first study to see what is triggering, quote unquote, this, because right, the majority are gonna have EGFR. What is triggering that? Is it more family history? Bigger deal? I think that's gonna be a big deal. Or is it, the cooking index, right? So we know certain areas of China, 30% of the Asian women have lung cancer in these poor countries where they cook with coal all day. That was older data, but so we know cooking index was a big thing. Guess what? History of COPD, even in people that don't smoke, is a big deal. History of TB is a risk factor. This is all based on the talent study, but this is all what the Female Asian Never Smoker Study is looking at, all these different factors, and then we're gonna combine that and figure out what are the biggest risk factors so we can tell you and tell other people, these are the people that maybe need to be screened to catch it early. So hopefully that answers your question.
Could I get the information of how to find the results of the study?
Oh, yeah. Would you be, sorry, can I ask, are you a control or or lung cancer?
No, just curious.
Yeah, I was just saying, because you could still sign up for the study, but
It's
yes.
ongoing. It's ongoing.
It's ongoing
The
right now.
study's
So
not.
I'm not trying to.
The study's
push
not
you.
completed.
It's not completed, so we still need people to fill that out. And this is again the whole Asian American thing, right? This has taken 4 years to get not even 600 patients, because Asians have our own unique. You guys probably are all nodding your head. You understand? Like, why don't we do it? I don't know. Stigma, family, not enough time. Guess what the answer is? It's passive refusal. What does that mean? I call you guys, right? It's me doing this, right? Because I call you, don't answer. You think I'm spam, or you think I'm something else, right? Or even though I'm the doctor, like, they don't call back, I'm too busy, or there's a language barrier and I have to use a thing. So, right, that's to say we need to support us Asians, right? There's thousands of Asian women out there in the Bay Area that have this, but yet it's taken 4 years to get 453 to fill out the survey. We need more. We need to do better.
So, how do you sign up for the fan study?
Yeah, it's basically a QR code, but I can give it to you. Like it's a QR code / it's on the website, like USCSF fans. To full disclaimer, we have enough controls, so Asian women that don't have lung cancer, except we are looking for any Asian woman over the age of 80. That's not lung cancer, because you can imagine those are the hard women to get to want to do it. But any Asian woman, and you have to just be 21, right? 21 and above. That is any Asian right now that has had lung cancer diagnosed any stage in the last 18 months, we are actively recruiting. There we go. Okay.
Side
we'll
question.
talk afterwards. Yes.
Side question. Okay. So it was just one quick side question. Radon.
Yeah. Radon's huge, right? Radon's it's the biggest cause of non-smoking lung cancer that we do know of. But guess what? The hard part, and we're asking that in the survey. The problem is not all you know, and I don't even know. I should test my house. Yeah. We don't know what the radon levels are. Now, when you buy a house right now, you can get the radon detector and find out. But it's radon, right? Like Dr. Lin said, radon is the #1 cause of non-smoking related lung cancer that we know of. And that's what does that mean? That's uranium that turns into radon, the elements that's in your soil at your house that you live in and that you just don't know. And tends to be, now this is a little dicey, but it tends to be, we see it in certain areas and neighborhoods maybe than others. You can imagine maybe older areas, right? Versus maybe a new build. But if you have a new build or a late build, doesn't matter. The bottom line is I would get a radon detector. I will know, I know that a lot of my colleagues that are younger do test that when they look for their house. And I should do that. I have not done that because I have a newer house, but I could be wrong, you know? It's on old property.
There are actually maps you can look up your address and see what the radon rate is in your neighborhood.
There you go.
Do you want to share one?
But it's something, it's something we don't talk about much. Monica. Oh, sorry. She had a question. Sorry. She had a question.
I actually caught stage 1 lung cancer. So, and I'm 71 years old. So I want to know what parameters should my daughter be looking at? You know, it's not covered to do a scan, send them to Taiwan or Hong Kong, but what should they do? How frequent should they test? I mean, because mine was one of those random, I wasn't in a car accident, it was a random find. But yeah, so I mean, what would you advise until these studies come back?
Yeah. So we were talking about this earlier. So you asked 3 different doctors, and we have 3 slightly different recommendations. I don't know what Dr. Sung's recommendation is.
Oh yeah.
Yeah. I tend to think again, have I had a 25-year-old banker in Manhattan with a pluripotent malignant? Yes. But that's one in my career. So I do think that with a first degree, especially, I do think in the 40, 50 range, probably more in the 50s, it's going to be that risk-benefit discussion because it may very well that a spot could be picked up. And that's actually most of my consultation for lung nodule is to calm down that. I walk in the room, a patient's on the wall, basically because they were told to come see me because of the lung nodule. But statistically speaking, that nodule is benign.
Yeah.
So I think that if you understand that, then if she's in the 50s range and mom has lung cancer and never smoker, then if you find a place that has affordable to you, I think all power to you guys to do it.
So just
Around age 45 or 50?
Well, yeah. I mean,
nobody really
we can
knows.
say 45, we
yeah.
can say 50, but
Yeah,
you know.
So doctor, so
Well, the thing is that once you pick up one, it becomes an incidental nodule for me. Then I have now the ability to request not a lung cancer screening CT scan, but to go on as an incidental lung nodule diagnosis, and I can go on with what's called the Fleischner guideline.
Right.
So, and it does allow me some exercise, freedom to exercise. That's fine.
how often should they
But
get
that's
it?
what we don't. So that's a great question. That's what we don't know. But but what I tell patients, that's why I don't recommend. Like I have my med student. She's like 25 right now. She's got 2 family members. I've told her not to get it yet. It's too early because you may catch something, and the problem is you're still going to have to get all those CT scans, and there is a risk. And many of you have seen that paper. There's a controversial paper about increased CT scans increase your risk of cancer. That's different. We're not going to get into that. It's like high dose, the IV contrast CT scans, and it's a little bit for everything. But bottom line, there is a risk if she's 25 and she's getting scans every year. That's probably unnecessary because those nodules probably, even if we solve something, aren't going to do anything. So what I say is that's why we're kind of saying wait till she's a little bit older, get the first scan. If there's nothing on there, there's a good chance she's going to be fine. Now that's me just saying hearsay based on some of the data, extrapolating data, but that's what I tell patients. The real lung cancer screening, what Dr. Sung is talking about, the benefit is to get it every year annually. That's in smokers. We know that. 60% of the lung cancers were caught on the second or third CT scan, not the first. So you're not out of the woods. The problem in non-smoker Asian young women, we don't know that answer. And so that's why a lot of negative people are kind of like, well, no, that's why they don't want CT scans because because of this issue. But I would tell you is to get a CT scan when she's a little bit older, and if that's clean, she's probably okay. But we don't have an answer of, I think every year is probably too much overkill, but we don't know. Maybe every 5, every 10, we don't know. And that's why we need more data on it. So that's kind of why it's yeah.
And also, if there are symptoms that persist, that's unexplainable,
different, yeah.
right?
Then you
Then
get a scan. Yeah.
That's
You could
diagnosis.
get it.
That's diagnosis.
Not screening.
Yeah.
That's diagnosis.
So-
Yeah.
But screening is gonna be a hard question, and hopefully studies like this will help us.
And it's hard because, as Arthur said, the scans also are decreasing your radiation. So then, what's the cumulative risk? And then how often do you do it? So there's a trade-off there. I think in Taiwan, they're actually recommending every 2 years, but they're starting a little bit later.
Yeah.
So, there's a trade-off for everything.
Yeah, they started Taiwan. They did 55 to 75.
Yeah. Monica, sorry. We've been very patient.
So I'm a guinea pig for a lot of different clinical trials as an Asian, so I'm proud to do that. Anytime that people have anything, want some Asian, you can call me. But the questions that I have is, I just recently, today, in fact, read the newspaper. Every county have a grant. You're talking about NIH, I'm talking about local grants, whether it's Santa Clara County, San Mateo County, San Francisco County, would have some kind of grant, 1 to 2 million for each district for education, migrants issues, outreach and all that kind of stuff. Have people consider applying, for example, Stanford CARE for some of these screening programs for Asians, since Asian is, according to what you said, 33 point something % of the whole big, kind of area, to allow free screening for people that walked in.
Ooh. The problem, so I know what you're talking about. Did you guys want to take over? Or, this is hard. So the problem is that screening for lung, and this is to get interesting. So eventually we're actually trialing blood tests. And even there's actually a urine test out right now, they're trialing. And then, so those are going to be cheaper, right? If you have a blood test, right? Like colon cancer screening has changed the face of the world because you just poop on a stick. And if that's positive, then you go to colonoscopy versus getting colonoscopy, which is super expensive and uncomfortable, right? So we want to.
Which one is the more?
No, but that's what I'm saying. The
economic,
problem is for lung cancer screening right now, to get a scan, it's a CT scan. It's expensive, and it has a radiation thing, and you might catch other things. And so, in terms of finding other things, so it's harder for lung. So I think the true way to really do what you're talking about, and this is what we're doing also in the research site. And there's actually on the East Coast. Sorry, I didn't want to leave them out, but at NYU they're looking. They are getting a blood test in addition. Like a blood screening test in addition to a CT scan. And the idea is, yes, if we just had a little blood test that's cheap and easy, that we could screen these people and catch this early enough, that'd be great. Right now, the problem is the blood test isn't specific enough for screening. It's specific enough if you have stage 4 lung cancer to follow it, but it's not specific enough for screening. They've been working on it for 10 years, but that's the idea of where we can get there. There's not enough money with these small communities. I've gone to these communities, right? They have Asian grants. Do you want to know how much they're Asian? I'm not going to rip on them, but I'll tell you. How much do you think they are? They're $1,500. You can get a grant for $1,500. That will pay for one CT scan. And that's just going to pay for the CT scan itself, not for you to get the results. Who's going to read it? Who's going to follow that? So for Asian, they're limited on their funding right now. I love your idea, and I'm not against it. But if you do, CARE, I'll be honest, this is not a plug for CARE, right? I don't work for Stanford. CARE is the only group that does these seed CARE grants because they have good donors like you all or Silicon Valley that give money. They give $50,000 grants that they just got, which I didn't get, which is okay. It's okay. But Natalie Louie got for a screening grant, for a screening study, okay? $50,000, and they gave out 3 or 4 of them. They give them out every year, and they do other things. So that is where we can do. So it's not a plug, but Dr. Lin's right. If we can put money into that, or if your kids that own Google or whatever can put it into something for Asian, they should put it into CARE, to be honest, because there's not many other Asian groups that have that, or they do have Asian groups, but they're going to fund, which is okay. I'm not against mental health, but they'll fund mental health, or they'll fund diabetes, or the big Asian thing is liver cancer, right? Hep B and diabetes, osteoporosis, all big Asian things. Don't get me wrong, but we're here to talk about lung cancer, which is the #1 killer. And cancer is the #1 killer overall of Asian Americans. It's not heart disease. I love heart disease. But it's not heart disease that you die of. It's cancer. In Asians, not in Latin, black and white, it's heart disease. So again, you got to, the priority wise.
Yeah, I've never seen those $1 million grants, so I'm happy to review it. I somehow think there's
probably newspaper.
Yeah, I mean, there's always some catch right? So yeah.
Should find
So I think she had a question first. Sorry, Sally.
Okay, my question is not about preventive screening, but someone already diagnosed stage 4 lung cancer, EGFR, taking Tagrisso, very effective target therapy. My question is, we heard that eventually this medication will not be effective. So probably because of the gene, the cancer cell have mutated again. Any factors that contribute to it, or anything that the patient and the family can do to slow that so that it could be as long as effective.
Yeah, we don't know why any particular person gets resistance, right? There's a lot of, so the challenge is when you get resistance to osimertinib, Tagrisso, it can be very heterogeneous. Like with the first, second generation tyrosine, these are called tyrosine kinase inhibitors. The reason why Tagrisso works so well is they anticipated the next mutation. So they cover both. That's why it works well, because you're basically covering 2 mutations. And we actually now do not yet have a standard of care what to do. I know this intimately because this is me. We don't know what to do if you become resistant. There's a lot of different options. And there's a lot of new stuff coming out, a lot of new studies, right? So yeah, there's nothing we know that on an individual basis. I mean, the big thing, of course, make sure you take your medication regularly. You know, we worry about people who don't take it regularly because we know with antibiotics and things like that, you know, you can get more resistance if you are inconsistent about taking your medication, right? We know that because it's like natural selection, it's like evolution, right? So it's interesting though, we've seen a lot of people who become resistant, they go to another therapy, and then they get different types of therapy, they get treated, and then they're not resistant anymore, and they go back to osimertinib. So it's very interesting because it's probably a heterogeneous tumor cell population where some get resistant, not all of them get resistant. It's not like all of them suddenly develop resistance. So I don't think we have an answer for your question of what to do. The FLORA-2 study showed about a 25-month progression-free survival, which is great. That's awesome, right? Yeah. Next question. I will start to wrap it, Sally. Yeah.
So, thank you, Dr. Lin. You as a lung cancer for never smoker patient, also as a co-founder director at CARE. What could you share with the audience? What CARE is doing in terms of lung cancer for people who have never smoked?
Yes, absolutely. So you're a plant. See, Sally's our executive director. She's the planted question. So, you know, our Stanford is, you know, starting a new cancer initiative. You know, we're probably going to open up a big new cancer campus and raising money. And their priority is going to be, first cancer they're going to prioritize is lung cancer. Stanford CARE has made it our moonshot, our priority within CARE to support lung cancer in never smoker Asians, so Asians who have never smoked. And that is around not just seed grants, education, community events that Nina's driving, but also raising money for research. So there are so many, you know, as we all talked about, there's this gap in research, and even before this current administration, there's a gap from translational research, you know, basic science, translational research, to get new treatments into clinical trials, into phase 1. There's a gap in translational research for these blood tests. You know, we need more of these. So we've got colleagues working, Professor Nathaniel Gray, he did some of the foundational research that enabled osimertinib. We recruited him from Harvard. Professor Max Dean, he's doing a lot of this kind of biomarker, liquid biopsy kind of approach, right? So to do that, we need funding. You know, I was kind of joking about donating money CARE, but, you know, industry, you know, and then we have other things like nonprofits and universities. And we do really need your support, you know. We need your support because we don't, you know, without the NIH, and NIH historically is a very conservative funder of research. It's a major, we need NIH. NIH is awesome, but they tend to be very conservative and they don't fund translational research. Translational research is going from basic science into a treatment that gets into patients. So, you know, as CARE, we need your help. We had this great lung cancer summit a few weeks ago. Amazing. We brought together all the experts at Stanford, many of the experts at Stanford for the summit, and exchanged ideas, heard about what we're doing, what each of our colleagues are doing. And next year we're going to expand that to include experts from outside of Stanford. So there's really a lot to be done, and we appreciate your support. Yeah. So maybe one last question, buddy. Oh, I'm back. No, sorry. Go ahead.
Oh, just to clarify, if do you recommend screening for people with no family history if you meet the other criteria?
That's a tough question.
That's a loaded question. I like it, but in my truth of all truths, I would love that, but in reality, I think it's probably overkill. So I mean, what you're asking is you look 30, so whatever, 40-year-old Asian female with no family history, Asian female, that's overkill right now. I think that's overkill, where I say that is over. It's the family history that's really the main factor. Even out of the family history, you still have a low chance of getting it, but it's the highest risk factor. So I would say 50-year-old Asian female, I do not recommend right now. Like, I'm not recommending my mom right now. She's older than 50, but to get lung cancer screening.
I wouldn't do it if you don't have those risk factors, because it's, again, like Jeff said, it's not your first one that's mostly catching it. You're gonna have to keep doing it. Yeah. That's screening. So it's hard to, get that as an ongoing process. So without some additive risk factor that is more known, then I think that then you get those false positives.
Yeah. Right.
And the false positive can do more harm than good from a psychological standpoint.
But it's interesting, in Taiwan, I think their national screening is following the talent criteria, right? The talent study criteria, which is not just family history. It includes the smoking,
the other risk factors,
COPD, TB, things like that.
But again, that's other risk factors. Right. She was kind of saying no risk factors.
Sure.
Right, and we got to remember, the reason why we need to do that stuff here is because I've never been to Taiwan, but remember, Taiwan, they're all Taiwanese or Asian, right? So they could be different than the Asians here, regardless if you're born here or not born here. So that's what we don't really know, and I think we'll see. Hopefully we get those numbers, but we may not, because they're just by population. It's just different than what we are here. That's why we need to study it here first. And we don't want to go overkill and just start screening, right? Because if I just open my study up and say, I'm going to screen 40-year-old women, Asian women, it's going to be a negative study. And then we're just going to hose ourselves for the rest of the time. So from the research standpoint. Yeah. Anyway.
But do you think, because of the talent study, let's pick 55, because that's what the talent study said, included. If, could we start saving lives now by screening people, let's say people from Taiwan who are in America?
Okay.
55, family history.
Oh, absolutely. But that's the family history.
Family history. No, that's what I'm saying.
Yeah, here.
Right.
That's the study literally my study. I'll tell you what my study is. 200 women, 50 and above, with a family history of lung cancer. Right. That's who I'm screening.
It's a hard thing for me to answer that, because when we talk about screening, we're talking about an individual for the screen, one-to-one, but we have to think about societal. Yeah. And to just CT every never smoking Asian woman that's over the age of 40, that we're not gonna pass it through Congress.
Right.
You just won't. Not even a Democrat or Republican. It'll break the bank.
Yeah.
So we can't afford that as a society. But one-to-one, if I were to talk with you, it makes sense. But we have to step back a little bit also at some point. That needs to have some of that threshold to be met before doing that.
It's very interesting. Before I was diagnosed with cancer, I would agree with you.
Yes, absolutely.
Now that I've been diagnosed with cancer,
absolutely.
I'm like, screen, pay for it. I mean, that's to me.
I get it.
I'm like, but now it's not. Remember, now it's not covered, so you're paying out of pocket.
Patients in Chinatown, what percent of Asians actually lives in poverty in our country?
They're not going to be able to afford
20-30%?
It's actually high. It's very high.
20-30%.
Yes.
Paying $150 can be decision between a CT scan or food on the table.
Yeah. It's $1,200 at least that I know of. At ours.
So
1,200.
from that standpoint, I do have that.
Silicon Valley Diagnostic Imaging, $150.
Now, there are a
That's
lot of
validated.
grateful patients at Stanford and Kaiser that, I have plenty of patients because, listen, we're in a very well-resourced area. We're not billionaires, we're trillionaires.
Yeah.
But, I got funding just to say, oh, you're going to Chinatown. I'm going to fund your research.
Yeah.
And I got a six-figure money. And I'm going to devote that to Asian and lung cancer there.
Yeah.
So there's grassroots, there's holistic, there's political lobbying,
Yeah.
there's industry. I think all hands on deck.
But it's interesting, just last interesting point, about the bankrupts. The uptake rate of screening which is covered for smoking lung cancer is very low.
1%?
And it hasn't broken the banks, right? Yeah, so it's interesting.
But we want people to. enroll.
Yes. No, I know,
We want
I
them
know.
to be 90% like
No,
colon
yeah,
or whatever,
yeah,
right?
Yeah.
So.
Okay, any last questions? Okay, one last question.
So should males be screened as well?
So, yeah. This is great. You're you're causing trouble.
So I'll
I
just
think there's a psychologist on hand.
I know, you can mediate.
I'll just answer this. So in the talent study in Taiwan, they do allow
They include
males.
both, yeah.
They include both, but the percent of males was 26.1%. So the majority were females that were catching the lung cancer, and that's exactly what we see here. It is more rare in Asian males, but Asian males that are non-smokers are much more likely to have lung cancer than white, black, and Latin males. So if that answers your question, so it's more common in men versus other race ethnicity, but women by far, Asian women by far, it's much more common.
So in Taiwan, the government's screening both men and women.
Yeah, but again, yeah.
Great. Yeah, last comment.
Can I just make a different point? And I think these are really great questions. I think and you alluded to this, the mental health consequence of even the screening anxiety is also not a trivial factor. There's pretty good literature that when you've been screened and you're waiting for the next thing, a biopsy, whatever, your anxiety understandably does go up. So and that anxiety, it's not that now that you did not get a diagnosis, you go back to normal, as it were, right? There's actually things shift. So I think there is a psychological cost to some of these choices as well. Mm-hmm. And it is understandable that we worry about the disease. And then we have to temper it with all the other arguments, the financial, the societal burden, implementation, scaling, all of those things. And what gets lost sometimes is the psychological burden of even making that choice. A lot of the questions, should my daughter get it? Should I go? Should my husband go? There's a lot of that sort of speaks to some anxiety, which is understandable. But I think we have to be thoughtful in how we approach that and know that if we're making that choice, then that has other consequences. And it's not that goes away and we go, oh, what a relief, because now we're primed to think about it again. So.
Well, no, we're out of time. So if you want to ask questions, come up. Hopefully some of the panelists can do that.
Funding.
Okay.
Oh yeah, we can talk about
Trustee
it.
have these matching grants.
Which is?
Just announce it very, very last minute.
Who? Sorry, who?
Trustees.
Oh, the
Stanford
trustees.
Trustee have a matching grant. Daddy, can you tell?
You mean the donation?
Deadline already?
the Stanford Day of Giving.
Oh, that's over 5 p.m. It ended at 5 p.m. Yeah. But we still want your money. Please donate. Thank you for supporting CARE. There's a QR code right there. Okay, thank you.